Welcome to the webinar, Predictable All on X Using Digital Workflows. This lecture will be presented by Tremaine Watkins, CDT, and we are going to begin shortly. And with that, it is my distinct pleasure to introduce Tremaine Watkins, CDT, Director, Strategic Education. Tremaine has been working in the dental industry for more than 35 years. He has extensive experience fabricating analog and digital prosthetics with expertise in implant-supported and retained restorations. A respected lecturer on both laboratory and clinical aspects of restorative dentistry, Tremaine trains technicians and provides clinical support in case planning, troubleshooting, and implant placement. And now it is my pleasure to say, take it away, Tremaine.
Thank you very much, Jessica. Jessica and I are good friends, so I know that she didn't just lock me out for no reason. No, just kidding. Thanks everyone for joining. Really appreciate it. My goal tonight is to give you a predictable digital workflow for your all-on-X cases. If some of you have been in some of my courses in the past, I kind of have the gamut from fully theoretic to much more cookbook. And this will be some theory at the beginning, but then we're going to get pretty cookbook. I'm hoping that by the time you're done with this, you'll be like, okay, I got a plan. I can do my next all-on-X case following one of these workflows. I'll have a couple different options in here so you can pick something that makes sense for you. Like Jessica, I got a little bit of housekeeping to do at the beginning. So I am an employee of National Dentistry Corporation, and I was paid to make this presentation. Other than that, there's no commercial support on this. Any brand names that are referenced in here are purely for case examples and educational clarity. It doesn't mean that I'm trying to promote those. And obviously, as you're implementing this, you'll want to follow your state laws for best practices. So these are our learning objectives for today. We're going to start with some foundational all-on-X concepts. And then we're going to talk about options for provisionalization. We'll have 3 options, so that way you can kind of pick the one that makes the most sense for your practice and your patients. Go through the records process. And then our goal is, and I'll show you the slide on this. I got a little slide to keep us on track. We're going to go through in no more than 6 appointments, from the initial records through surgery to delivery of the definitive prosthesis. So that's a pretty efficient workflow. So all of these resources are really, really good. I'm going to reference Dr. Stanley's talk, the second one, quite a bit. For those of you who haven't met Dr. Robert Stanley before, he was a PhD engineer working for NASA, and then he married a dentist, and he thought, well, dentistry is cool. I'm going to go to dental school. So it's kind of he has an interesting perspective because he tends to approach things from an engineering perspective. And I guess I like that as a dental technician because that's kind of how we deal with things as well. All right, so you'll see this slide all the way through. And what my goal is to use this as kind of our organizational principle. We're going to follow this workflow. So these are our 6 appointments at most. If we deliver a prosthetic on the day of surgery, then obviously it gets us down to 5. And so you'll see that as this slide keeps popping up, you'll see sections highlighted, and that's what we'll be addressing at a specific stage. So here we go. All right, I love this saying, and I kind of adapted it for all-on-X. All-on-X therapy is a prosthetic discipline with a surgical component. So I'm sure you guys have heard that about implant restorations as well. But when a patient stops by your office, they're not like, I feel like I have a titanium deficiency. If you could put a few screws in my head, I'd really, really like that. Not very often. I mean, most of the time people want beautiful functional teeth, and they're willing to undergo what we say they need in order to achieve that result. So I think when we use a prosthetically driven process, and this will be a very prosthetically driven process, it gets us most aligned with what our patients want. And then the second thing is that there are, as you guys know, biologic problems that we can manage at best. But we have control over where the implants go and the alveoplasty, if necessary, that's done. So the restorative envelope that we create for the case, that we can control. And so we want to make sure that we are putting ourselves in a position for success by how we do that. Let's talk a little bit about digital alignment of records and digital records in general, since today we're only going to be talking about digital. I think there's a couple times where I talk about byte blocks, but by and large, I'm trying to focus on, I'm going to pretend like analog doesn't exist, and we're going to do digital workflows as much as possible. So let's talk about the nature of a digital file that we use in dentistry. Every digital dental file, whether we create it in an iOS in the mouth or a lab scanner, it's a point cloud. In the STL files that are most common, and I guess you'd say kind of the generic format for dentistry, those points are grouped into triangles. And each of the points of the triangle is designed by its XYZ distance from a given point in space. This often invisible point is called the origin point of the file. Even though you can't see it, it's very important. Now, when you want to say that two files are aligned, what's happened is that those two files have been set up so that they share the same origin point. The reason that matters is that once that's been done, you can use those files with confidence, knowing that even if they show quite different things, that they're related to each other correctly. We're going to be talking a lot about file alignment, and so I want to make sure you guys understand how that works. I'm going to use iOS byte scans as an example. So let's say you're taking reference scans for a case. So you start with the mandible, you take your occlusal, lingual, buccal, you see the file created, and behind the file, there's an origin point. So the software takes one picture, takes another picture, compares, finds common areas, and gradually by stacking them up, builds that three-dimensional image with a common origin point. So now you've flipped to the maxilla and you get the same result. The byte scan, though, is quite different. You start taking your byte scan, you see the data, and then all of a sudden, pow, the two arches snap together. That's really important because what the software has done is it's taken common points between the maxilla and the mandible using your byte scan, and now they both have the same common origin point. So if you align the upper scan and you import the lower scan in the same alignment, you can trust that that byte is being preserved. So why do we care? As we're going through this workflow, we're going to be talking a lot about taking different scans and how we'll be aligning them to each other. You'll find that at times we're going to be taking scans. For instance, on the day of surgery, we'll take our first scan. We're not going to ever make anything on that scan, but it's a critical scan for getting alignment to the preoperative and the postoperative situation. And you guys know All-on-X patients are probably, except maybe denture patients, are probably the most variable group there is. So we're going to be talking about this is a workflow that'll work for most patients, and I'll highlight some times that can be a little bit challenging, but you'll find unique situations. And so as you think about how am I going to align these files predictably, it'll guide you in dealing with those unique situations. Don't overlook your laboratory as a resource. We do a lot with file alignment, and if you have a specific situation, send us some pictures and we can work through it with you and figure out what's an effective alignment strategy so that you get the predictable results you want. So when we're talking with our patients, we want to make sure that our presentation is aligned with their main concerns, time, money, and pain. For instance, one of the cool things about this workflow is that it's 6 appointments or less. So when you're talking with your patient, you can say, you know, I use the latest technology so that you only have to come to my office 6 times, or, you know, you can add in some follow-ups, but you can show them how you're saving their time. I have a bad example of this that I want to use to kind of illustrate how to not do it. So I was in Baltimore supporting a lower All-on-X case, and the patient had already had an upper. We were doing the lower guided, but the upper had been a freehand with a denture conversion. and it was the same specialist and general dentist team. And they said that the upper was like the worst case that they'd ever done. It took them 8 hours. They weren't super happy with the result. And they're like, we never want to do that again. So we got in there, we did the case, and we did it under local. And start to finish, it only took us 2 hours. And I was like, well, compared to 8, we're rocking it out. That's awesome. So since it was local anesthesia, I thought, I wonder what the patient thinks about this. So I asked him what he thought. And he said he liked the teeth. And then he said, but boy, it took you guys a long time. I'm thinking to myself, 8 hours, 2 hours. What do you mean a long time? I mean, I didn't say that. But I realized he had been asleep for the previous one. So all those struggles, those are transparent to him. He went to sleep 1 minute and woke up the next minute with some teeth. So this was a good example of, as I was evaluating the case, I was evaluating it from my perspective, but I needed to change and be thinking about it from the patient's perspective. So we'll talk a little bit about patient communication, but just make sure that as you're thinking about your workflow, you're presenting your treatment, that you're presenting it in a way that is most meaningful to your patient, not necessarily most enjoyable to us. All right, let's talk about a little fundamentals. Every all-on-X case we treat falls into one of these categories. And they're separated by how much hard and soft tissue they replace. And I'm not going to go top to bottom. I'm going to go in order of prevalence. So FP3 restorations are the most common ones that we do. They replace both pink and white tissue, as you can see. Oftentimes, they require some alveoplasty. They can usually be restored with the least number of implants, and you don't really have to worry about the transition lines showing. As I said, they're probably the most popular right now, but they might be trending a little less popular, let's say. FP1s only replace the teeth. So they usually don't require alveoplasty, which is part of what makes them popular, but they do require quite a few more implants, and the degree of precision is very, very high. I'll talk about this a little bit more in a minute, but you want to know what you're getting yourself into when you start on an FP1, because the cosmetic demands are affected by the surgical result. FP2s, you rarely see them planned that way. They are usually an FP1 with additional bone loss. You'll either see longer teeth or perhaps a little bit of pink. They're usually not, you don't see a lot of guided or planned cases that are FP2s. RP5s, they're an overdenture supported by implants with resilient attachments and tissue. So basically a locator denture. They're, as you guys know, they can be a little bit less stable than what a patient might like. They're usually a more affordable option. And they're the one of these that can potentially have bone resorption because of the, like in this case, the pressure of the denture on the heels of the tissue. RP4 restorations are getting more and more popular because they're a removable that is fully supported by implants. So it gives your patient the opportunity to have a removable restoration that's just as stable as a fixed restoration. So let's start with a question that a lot of times we're not even asked. Should we deliver a fixed or removable restoration for this patient? I love that old saw that if all you have is a hammer, everything looks like a nail. And I kind of feel like in all-on-X, we can get that way with fixed. It's like, okay, I'm doing an all-on-X, so that means we'll be fixed. We do need to think about some things when we're making this decision, though. As you guys know, the primary factor in the long-term success of these cases is hygiene. And fixed cases are difficult to keep clean. Another thing is that there aren't a lot of studies that show this, but a couple older studies that I saw, they did a full fixed and a full removable restoration, let the patient wear both in random order, so it wasn't like they always kept the one they were wearing. And it wound up being about half and half. So your patients may be more interested in a removable restoration than you might think. Now, in the past, we kind of had to decide between, well, fixed or sturdy and stable, and removables move a little bit, but we'll talk at the end about different prosthetic options. We now have removable options that can be just as sturdy. So that can be a factor. Removable restorations are almost always resin-based, so you know that they're going to wear out and need replacement, so that can be a factor. So if you have an opposing set of crowns or something like that, you may need the harder materials that come from a fixed restoration. Or if you have a patient that has a history of parafunction, again, you may need the strength that you're going to get from a fixed. If you have a patient who lost all their teeth due to perio and doesn't seem to be very interested in home care, removable may be really important. One other thing that a lot of times people don't think about this is that some implant systems have more prosthetic options than others. And especially with removables, sometimes you can be limited by the options available for the platform that you have. So as you're selecting your implant system, you want to think about, does this give me all the options that I want, or am I going to be kind of forced into a narrow lane? FP1. So let's talk a little bit about FP1. When this procedure started, the solution was a titanium reinforced acrylic restoration. Because of strength concerns, we needed 15 to 18 millimeters of restorative space. Well, by definition, that was going to incorporate some pink, since most people don't want a 16 millimeter long central. And the goal was to only use 4 implants. Obviously, I would say zirconium is carrying the day today. And so with zirconium, we don't need as much restorative space. Also, as we're trying to do the least invasive treatment we can, preserve as much hard and soft tissue as we can, FP1s are getting a little more popular. And that's great. But we kind of need to think about these cases. My patient on the top left is a little bit atypical. Oftentimes with these cases, you're going to see the transition line. In other words, you're going to see where the prosthetic sits on the gums. So we're going to need to have really ideal gingival scalloping everywhere that the patient can see it. We also need to avoid major asymmetries. If there's more bone loss on the right side here than the left side, the gingival aspect of the restoration is going to look canted, and you can have hear the patient saying, "Oh, I think my teeth look sideways." It's like, well, you look at the incisal edge, and it's nice and straight. No, up at the gum line. Can you fix that? Kind of. So a lot of times these cases wind up being almost a full arch crown lengthening case. One thing you can do to help yourself out with these is to get a CBCT scan and digitally extract the teeth and look at the bony architecture. If it looks pretty symmetric, it might be a good case for an FP1 if you can get enough implants in the right position. But if you're seeing major asymmetries, it may not be as predictable. I would strongly suggest that on these cases, you need to underpromise and overdeliver. In terms of, oh yeah, look just like teeth. If you say that, make sure that you understand what just like teeth means to that patient, and then you can deliver that. The other thing, and you kind of see it with this case, is the implants have to be perfect. They have to be placed just like they would for a crown and bridge case. And they don't really need to be placed where the teeth are now unless they're ideal. They need to be placed where the teeth are going to be. So I love guided surgery anyhow, but I would strongly suggest using guided surgery for this, because to my way of thinking, that's the only way you're going to be able to know ahead of time exactly where the teeth need to be prosthetically, so you can get that precise placement. Because again, it's like you're placing 7 single lateral implants or single central implants. So they got to be right there. And then last but not least, you want to kind of think about what configuration you might want to do. With this lower bridge here, I'd say this is pretty popular, which is a single arch all connected. But we also see a 363 configuration. We have a 3-unit bridge, 6-unit bridge, and 3-unit bridge, or even 4 3-unit bridges. It gives the patient the opportunity to floss and get a better hygiene result. So I think these are a great restoration. I think we're going to see more and more of them, but the level of surgical execution, the level of planning is, the demands are even higher than they are for a normal all-on-X case. So just make sure that you're putting yourself in a situation where you can succeed. Because of the restorative space, if you plan an FP1, it's nearly impossible to convert it to an FP3. So once you start down the FP1 road, that's the road you're on. So engineering principles. So I'm going to borrow some from, quote some things from Dr. Stanley here. So if we're going to have long-term success with our restorations, we need to understand the forces that they're going to be withstanding, and then we need to think about how are we going to help them with that. So bite force, obviously, is the major force that our prosthetics need to resist. If you think about your single tooth restorations, your materials options or your material selection might be quite different for a number 8 as it would be for a number 2. The reason is obviously because there's much more force on the number 2 case, and a lot of times you don't have the same restorative space. Occlusal force is huge for our all-on-X cases too. Because our patients have by and large lost their sense of proprioception, they tend to apply more biting force. The same patient applies more biting force to an all-on-X than they do to their preoperative teeth. And it can be as much as 4 times. So that's why a lot of times you only see really high strength materials for all-on-X cases, because we know that just from the beginning, we're going to be experiencing very high loads, and we need to have a successful plan to resist those. And then I got my little picture here of my larger person, my smaller person. As you guys know, bite force varies significantly from one patient to the next. And when you multiply that by 4, the variances become even bigger. So when we know that we're going to be in a high load situation, we need to figure out how we're going to deal with that. First, we need to select the correct materials. We may need more restorative space. We may need more implants so we don't have such long spans. We'll talk about some of these things later. And how do you know, besides just physical size of the person? Of course, you want to look specifically at their oral musculature, and then you want to look at their history. Of course, if it's periodontitis and there wasn't significant wear, you may not be in that difficult a situation. If all the teeth were ground down to the gum line, you know that we're going to be dealing with extreme occlusal forces. As you guys know, one other challenge with all-on-X is if we have a patient that had very poor dentition before treatment, and all of a sudden we give them a full mouth of teeth, sometimes old parafunctional habits can reassert themselves when they weren't really evident preoperatively. So we want to keep that in mind. What is it opposing? Is it opposing a denture? Is it opposing a full arch of crown and bridge, or something in between? Don't forget about bite splints. Bite splints can be an awesome way of protecting those restorations. And sometimes, especially with removable restorations, you'll even make an overnight restoration that's designed to, you remove the daytime restoration, put in a nighttime restoration that specifically serves as a night guard. So anyhow, a major consideration we want to make sure we take it into account. This is more of a trivial pursuits type slide. I don't know about you guys, but I always thought, if I'm planning a single tooth implant, I always try to plan it so the occlusal forces with the arc of closure are going to be right down the middle of the implant. I'm like, okay. And then all of a sudden, those rules seem to go out the window. Like, why is that? Why can we do tilted implants with all-on-X, and we really try to avoid them with single implants? And this is the reason. If you think about this being the prosthetic and this being the bone, these are the implants. So one of the interesting things about, if you think about like race car design or something like that, I like race cars, so I'll use that as an analogy. you wouldn't make a space frame that had all straight bars, because when force is applied, this could deform a little bit. So these angled implants actually serve as a truss and help prevent motion, horizontal motion between the two surfaces. So the reason they work basically is because they're part of a system. They're not a single implant. And then the other thing I wanted to point out is, if you think of this as the prosthetic, if this is rigid, we're going to get no bending force on this implant, and we'll get a little bit of force this way, but we're not going to be trying to expand this. If we use a flexible material here, there's a potential for applying bending forces in addition to compressive loading. So saying all that to say that when you're choosing a material, if you choose a more rigid material in general, it's going to create a more favorable result long term. Mandibular flexure. So I know that there are some opinions about that, but studies seem to show that there is some flexure in everybody's mandible. In general, it's posterior to the foramina. So that's why Dr. Misch came up with the A, B, C, D, E implant positions, where he put 5 in the symphysis. But we're going to talk about eliminating cantilevers as well, and sometimes that can be a little bit difficult. One of the things that can be interesting is if you deliberately do an FP1 style case and break it up so that you're doing 3-unit bridges, say, or 2-unit bridges, as case may be, behind the foramen, and then you're putting another bridge in the anterior. So you're deliberately creating a space. If you do a splinted restoration that goes across the foramina, you can potentially cause stress shielding, and that then your bone and your prosthetic and your implants are all fighting against each other, which may not give you the awesome result you want. We all know that there are lots of potential complications, but smoking is probably the worst. So I thought I'd put a slide in here just to remind you guys. When you're working with patients who smoke, it would probably be in your best interest to talk to them and their significant other and let them know that they cannot smoke during the healing phase, because it just makes the case too unpredictable. And it's probably not a bad idea to talk about the financial implications of losing their implants and getting to start all over again. If people are smokers or choosing to smoke, you'll probably want a disclaimer to help you out. And smoking is unfavorable for implants in so many ways. I have 3 here, but the more I read, the more I'm like, oh, this is not awesome. It seems to lead to a higher rate of implant rejection, for one, promotes soft tissue ingrowth around the implants, and to make matters worse, a lot of times it limits the pain that patients normally feel with failing implants. So it can take longer for you to diagnose a problem. So be careful with these cases. Don't let yourself get in a difficult situation where you did everything right, but the biology has been fighting against you. Transition line. I think we would all agree that we do not want to be the one who has this case. So transition line becomes a different issue with different kinds of restorations. When we're doing an FP3 restoration, we have to have the transition line above 2 to 3 millimeters above the highest possible smile line. We'll talk about that in the photographic records, but do yourself a favor and make sure that you capture that high lip line. It's so critical for your restorations. Now, FP1s, on the other hand, have different challenges. And like this case, you can see with the gingival architecture, it wouldn't be awesome to convert even to an FP1 because the implants are kind of positioned between all the different sites. If we had one here, one here, one here, the shape is not too bad. You could do a little bit of alveoplasty here and potentially come up with a pretty decent FP1 case. And you're like, oh, I'll get the patient to smile. That's easy. Well, those of you who've done very many of these cases know that these poor patients, many of them are dental cripples, and they've been practicing for years to couch their smile. Now, That doesn't necessarily mean that their muscles have quit working. It's just that behaviorally they've limited them. You give them a nice set of teeth, and all of a sudden they remember, oh, yeah, I'm going to smile from ear to ear. So the challenge is getting them to smile like that before we start the treatment, so we know what we're dealing with the transition line. So maybe you tell them to snarl. I know somebody say squint your eyes and give the biggest smile you can, but you have to have a predictable way to get that high smile position. If it were me, I wouldn't start treatment planning a case until I had seen that, because you don't really know where you're at. Now, if we're doing a prosthetically driven process, I guess it would make sense to figure out where the teeth ought to be. As you guys know, especially let's say for a full mouth case, the ideal tooth position and contour begins with the incisal edges of 8 and 9. For most patients, and this can vary a little bit, we want to see 1 to 2 millimeters of incisal edge display with the lip at rest. We want to make sure that the incisal edges don't interfere with the arc of lip closure, and that we get good phonetics, especially if they say a or when they're using a really soft F and V. Most people don't want to show more than 2 millimeters of gingiva at the high smile, and it seems like that's a number that's just going down and down and down. You're going to have some patients that don't want to show any at all. So basically, if you know where the incisal edge position should be, and if you know where the gingival should be, then you can use whatever your favorite proportion is, 80% on this case, and figure out the rest of the smile. So the width here is 80% of the length. The surface area of this is 80% of this one. The mesial, or the part of the cuspid that shows, 80% of this. And so you can pretty quickly kind of space out your teeth. We also know that in general, it looks nice if we line up the incisal and gingival of the cuspids and the laterals. We know that we want to do, say, a 0.5 millimeter to sometimes as much as 1 millimeter shorter, both gingivally and incisally with our laterals. And then there's a few other little rules that are helpful. In general, we want our centrals flat to the front. So in other words, when you look at them in profile, or you look at them from the incisal edge, they look fairly flat. Some cases look better perfectly flat. Some look better, I feel like, if you follow the curve of the arch slightly, but something to think about. We want these main line angles to be symmetric, cross arch. Sometimes if you're working on a big case and you look at the teeth and you look at them and you think they ought to look good, but they don't, kind of look at them from the incisal edges and look at the morphology, and you'll find, oh, the problem is that they're asymmetric in terms of the facial profile. Another thing that can look kind of weird is you look at a tooth and you're like, man, this area just looks weird on it. Some of the CAD programs that we use these days, when you stretch it, it creates a depression here. And in the overall contour, we want our tooth to be convex in this dimension and convex in this dimension. We want to make sure we have positive centric stops on all teeth in centric relation and no eccentric interferences on the cusp of the posterior teeth. In general, we're going to want to be doing cuspid rise with anterior group function, unless there's something very unusual about the patient. The other thing that I see continually changing is the buccal corridor. People seem to want to see less and less and less black space at the corners of their mouth. This also affects cuspid design. I feel like cuspid design is probably the most variable of the anteriors, because some people kind of want to see a little bit of a point and they like kind of having a little dark space around it. And some people are like, I want to see white all the way across, which has the effect of making a fairly flat point. We want to keep the neutral zone in mind, even though these restorations are implant retained, so they're unlikely to be displaced by the patient's tongue or cheek. It is going to be an irritant if we're well outside of the neutral zone. So we want to keep that in mind as well. So these are kind of some rules we want to follow as we're building our prosthetic plan that'll then drive in everything else. Okay, so you got an awesome prosthetic plan. Now what do you do? In this digital workflow we're talking about today, The prosthetic plan will be the teeth and the bite that the patient gets in the provisional on the day of surgery. Not only that, but those tooth positions are going to direct the alveoplasty if we do any and the implant placement. Again, the ideal implant placement is going to be determined by this prosthetic plan, not necessarily where the teeth are now. And there's a variety of different ways we can both evaluate this and present it to patients. With facial scanning or even with a 2D photo, a lot of times we can align our design to the person's facial photos and show them and look at it ourselves how it will look their mouth. 3D scanning is more reliable because then the design and the face are scaled 1-to-1. The results on that I've seen 4 cases, and they were right on. Every time was exactly the same as what we planned. So if you're looking to add a little bit of aesthetic predictability to your practice, maybe facial scanning is something to think about. Some patients are going to want to see the case in their mouth, or some of them you're going to want them to see it in their mouth. So sometimes you can do, once you have your prosthetic plan, you can do a nice additive bonding like this, kind of like a snap-on smile. If you have a denture patient and you want them to see, you might decide to do an economy denture, not because you need it for records, but just because you want them to see the tooth position and accept it. We do not want surprises. We want our patients at each stage to be like, this is better than what I expected. If we can get that, let's see, 1, 2, 3 times in this process, that's awesome. That's our dream outcome. And this is kind of our initial promise. So we want to make sure that the patient really understands what we're promising them and is happy with what we're promising. So there will be different levels, but part of that dentist-patient relationship is making sure that you're kind of reading your patients and you're like, okay, Mary Jane or Bob or whoever, they really understood what's going on and they're on board. Hygiene. Like we talked about, hygiene is the key factor in the long-term success of these cases. So when you're doing your initial evaluations and as you're discussing with your patient, they need to understand how important this is. Even a well-designed fixed case can present your less dexterous patients with a overwhelming hygiene challenge. And a lot of folks that we're treating had a history of poor hygiene that kind of got them in the hot water they're in now. So as we're working with them, we need to make sure that they can clean whatever it is we're going to provide them. Most of the time, we're going to be delivering a person a fixed restoration so we can get cross-arch stabilization for our implants, even if we might be going to removable restoration later, especially like with a conus or a locator bar or something like that. And you can kind of use the healing time with the provisional as kind of your final exam on hygiene. It's like I talk to them, I examine their teeth, I think they can do it. Can they do it? And if the results are very poor, you might be like, okay, well, I think we need to talk about removable restoration. Now, one other thing I wanted to highlight on this. Obviously, this was a straw man. This is the worst fixed case ever, and nobody could keep this clean. When I look at this as a dental technician, I'm like, boy, we really messed up on this because this kind of ridge lap is ridiculous. We have to design our cases so that they're flat to convex on the intaglio, or they're going to look like this. They're not going to be clean. And, you know, eventually we're going to get hard and soft tissue loss, and we may lose all the implants too. So this is an area where you can help us out in the laboratory by being a second set of eyes, especially on the prototype when we're going to the final. As you know, most of the time the ridge is convex, and there's always that temptation to just come over the edge a little bit. And both we as technicians and you guys as clinicians can kind of push back on it and say, you know, I need that more hygienic, or I'm not going to have the success I need for this case. So I think this is an example where we can each hold each other accountable to get the good results we need. How many implants ought we to have in a arch. I mean, we all know that it started out as all on four, and that's fine. I'm going to borrow again from Dr. Stanley, who's good at mathematical modeling, given his history. So he starts with all on four, none on three. And if you look at that with typical implant failure rates, the statistical success rate for an all on four case is 85%. Mathematically, when we put a fifth implant in, our potential success rate goes up to 99%. Now, if we lose the most posterior implant, it's going to be a problem with any case. But in general, adding that fifth implant can make a big difference. Here's another thing that we sometimes don't think about. Let's say we have a 3-inner bridge with a single ponic in the middle, and the load on that is X. So if we put in 2 ponics, the load on the ponics becomes 8X. 3 is 27X, and if we had 4 ponics, it's 64X. So, especially when you think about that our patients could be applying 4 times normal occlusal force in these cases, there are no materials. We'd have to make it out of unobtainium, which is an engineering joke, something that doesn't exist basically, to do 64X. 27X is pushing the limits. So one other thing that you see with 5 implants is now all of a sudden we don't have long ponic sections. So we're again putting our restoration in a more favorable position to avoid breakage. Now, so in the other thing we want to think about is how much load there is on different teeth. As you guys know, cuspids experience 2 times the occlusal load of any other anterior teeth. First molars 3 times any other teeth. So if we change this case and did 3, 6, we'll say 9, 11, and 14, that would give us the best case scenario. And because we're going to talk about cantilevers in just a second. So AP spread, let's talk about the definition first. It's the distance from the middle of the most anterior implant or MUA platform to the distal of the most posterior platform. And then we were taught historically that you could do a cantilever of 1.5 times that, which is probably true from an implant perspective. But we got to remember that the biggest problems that we deal with these cases are not necessarily implant problems, but they're more prosthetic failures. And sadly, the rules of physics don't get abrogated just because we're doing all on X. So let's compare a cantilever case, again, in theory, with a no cantilever case. Let's say that I have a 2-to-1 AP spread. So if I have a 10 millimeter AP spread with a 20 millimeter cantilever, and I put 25 newtons on the distal, so back here basically, if this were 2-to-1, then right here, I'd be using 50 newtons to try to stretch this screw or pull this implant out, something bad. Now, if I have implant here, and I put 25 newtons in between here, now all of a sudden it's 12.5, and no force trying to pry my implants out. What does this mean? It means there's going to be times where we may need to use a cantilever, but we don't want to just doing 1.5 times AP when we don't need to is just creating potential failure that we could avoid with different implant placement. So what about screw hole position? In general, we want our prosthetic screws through the cingulums of the anterior teeth and the central pit of the posterior teeth. We don't want our screws in the proximal just because we tend to have less material anyhow, so it's kind of weakening our restoration. And one of the things to keep in mind is that once we know where our teeth should be and where we want our screw holes, then we know if we need to graft the case. Because if we can't get the implants where we want them, then we need bone so that we can put them where we want them. So again, it shows how getting the prosthetic tooth plan early is so important because it guides everything, including potential grafting. Implant thread design. Who cares about that? It's just a marketing thing. Well, kind of. Bone has mechanical properties where it resists some stress better than others, just like any other material we work with. Bone is strongest when it's subjected to compressive force, but it's 30% weaker in tension and 65% weaker in shear. You're like, well, why do I care about that? Here's why. So when, let me do here. When we use a buttress style thread like this, which is kind of like the screws that you buy at Home Depot, this creates a shear force on the bone as it's being applied, which the bone is the weakest. So we're loading the bone in the way that it's least able to resist. On the other hand, if we use a reverse buttress thread like this, it's pushing on the bone and loading it compressively, so it's creating a more favorable situation for us. So even deciding on the thread design of the implant we're using has implications for the success of your case. Stress is the unit of force over area. So if we have a given force, say a person's maximum occlusal force, and we spread it over a larger area, the per square millimeter stress will go down. So to do that, we want to protect the bone to implant interface, because that can be a major region of failure. So when we use larger implants, especially larger diameter implants, we're creating more, we're lowering the stresses at the bone to implant interface, and again, creating a more favorable situation for our implants. Molars are a good example of this. They have 3 roots, so they have much greater surface area because they're resisting greater occlusal force. And mathematically, again, thank you, Dr. Stanley, if you look at the total surface area of an implant, you get much more, your surface area goes up faster by increasing the diameter than it does by increasing the length. The other thing is that I'm sure a lot of you have heard is after the first 10 millimeters, you're really not getting much load on the implant. This area is primarily to create stability for immediate load. So if I get a longer implant, I'm building strength in an area where I'm not going to load it anyhow. So by going with a larger diameter up here where the forces are greatest, I'm getting more surface area, so less stress per square millimeter. The other thing that's interesting is when you go from up 1 diameter on your implant, the fracture resistance of the implant itself doubles. So we don't see a lot of that, but doesn't hurt. So in general, with our all-on-X cases, especially if they're not FP1s, if we're doing FP3s, we want to use the largest implant we can get and still get our 1.5 to 2 millimeters of bone around it, because we're protecting that bone to implant interface. When we're doing FP1s or single implant crowns, on the other hand, we do want to think about the aesthetic results, and in general, you'll get the best aesthetic result if you measure the mesial distal width of your restoration and then place an implant that is half of that in diameter. Most of our all-on-X patients have seen the commercials and they're like, I want teeth in a day. I want teeth in a day. Let's make sure I get teeth in a day. So primary stability, immediate load is going to be really important. Those of you who heard me talk know I didn't hit the patient communication thing as hard as I usually do on this. I think I'll kind of salt it in as we're going along, but it's really, really important to manage expectations. If you think there's a chance you're going to have to deliver a backup denture, it would be good to have that conversation with your patient well before surgery. So, and do your best, especially if it's someone who's dentate or partially dentate now, to kind of explain to them what it's like to wear a denture so that they're not disappointed. Like our provisionalists, their first experience of what we're doing for them, and we don't want a massive disappointment at that point. So successful immediate loading has a few things. It's helpful to pick an implant that is contoured to create primary stability. Drilling protocol, for those of you that place implants, is super critical. Most of the time there's a manufacturer drill sequence, but you need to use your experience to say, I might stop 2 drills early on this one to make sure I get good stability. Another thing that can be helpful is if you have 2 implants that are fairly close together in diameter, you might plan for the slightly smaller one and then have the slightly larger one as a backup. Don't neglect osseodensification. Sometimes, especially in the maxilla, if you do some densification, you can really give yourself a leg up in terms of your primary stability. Of course, there's one ideal implant for each site, but if you're a little bit concerned, it might not be a bad idea to have a little bit larger one on hand just in case. Multi-unit abutments. I've seen cases, especially in some regions of the country, where we see all-on-X cases direct to fixture. So there's a couple of challenges with this. The first is that a lot of times we're tilting the posterior implants. As we saw, it can help with the overall stability of our restoration, but it also is oftentimes necessary to get AP spread without grafting. Now, the problem with that is that it's not just the implants that are tilted. Oftentimes, it's the channel through the tissue as well. So as we're trying to put this direct-to-fixture prosthetic on, we're having to thread the little projections into those tissue columns that can be a little bit challenging. And it's not just one time. Every time you take that prosthetic out, you get a fight with it again. Most people I know who've done that a couple times are like, this stinks. I don't want to do this again. The other thing is that we tend to get better long-term results if the tissue around the implant is undisturbed. And an NUA facilitates that because essentially this becomes the platform. We torque this to place on the day of surgery and we never move it. So it allows, depending on what you think about muco-integration, at worst, it allows a tissue to sit next to this MUA and form a pretty good seal. And at best, the tissue might actually attach to it and give you just an extra layer of protection for your implant. So you're going to tend to get better implant health as well. And then the third thing is when you're doing digital workflows always go to MUAs. So you're going to need to use a universal MUA if you want to do a digital workflow. Two things I wanted to mention about this. In general, most of you know this, but as you're selecting the angle on your MUAs, the point of the way you choose the angle and rotate it is so that this axis is parallel as possible on all the different sites, regardless of how much divergence there is between the implants. Different companies have different contours here. A slimmer contour tends to seat better with less bone profiling, which can be really nice on the day of surgery. And then last but not least, this is important. You'll find more and more companies are developing what they call a universal MUA, which is one that is honestly similar to a Nobel MUA. If it has a universal interface, it's going to give you the ability to do any of the digital workflows we're going to talk about. If you have an MUA, an implant system that uses a proprietary MUA shape, it will limit your workflows. So not only would I recommend using MUAs, but I would say you could make your life easier by using universal MUAs. Last but not least, how this relates to the tissue. We want this platform either even with the crest of the tissue or slightly below. If this is slightly above, it winds up pushed into the intaglio surface of the prosthetic, and it makes a little pocket that's difficult to clean. So when you're selecting your MUA collar height, it's better to have it just a little bit short than a little bit tall. Speaking of MUAs, modern digital workflows are models for all-on-X. That might seem a little bit reckless. And I remember the first time I heard that, I'm like, really? Really? But here's the thing. With the digital workflows we're talking about, you can easily get cross-arch accuracy in the digital file to 20 microns, and some are even 10, 8, so essentially perfect. So when we take that data and create a model, we're basically decreasing the accuracy of our case. So what we want to do as much as possible is get the fit of the prosthetic directly from the digital file. So obviously with these, if I'm inserting something in here, this one is okay because they're all linked. All the MUAs are linked in one prosthetic. But here I have to glue all these tie bases in, and the accuracy of gluing it can be a factor as well. So with this interface is exactly determined by the digital records that you take. So it gives us the most accurate fit. The other thing that's nice is that these eat up material space. So I can generally make this kind of restoration a little bit slimmer because I don't need to allow for this. I'm also getting rid of a potential complication because I can't have cement failure here when there's no cement to fail. One interesting thing about this, and we'll talk about this a little bit more later, is that this kind of workflow takes a special kind of screw because you need a screw seating surface that's optimized for a direct MUA workflow. So some of the implant or MUA manufacturers do have a screw that works great for that. Some don't. So a couple things. One is you'll want to make sure you know what kind of screw you want. And then you're also going to want to make sure as you're choosing your record taking system that it'll allow the use of the screw that you like. Vertical dimension of occlusion. As you know, every person has an ideal jaw relationship, but a lot of our All-on-X patients aren't in that position. Some can be over-open from past restorations, but some are going to be over-closed due to loss of tooth structure and entire teeth. Some of our patients are going to have a biologically functional ideal VDO, and we're going to want to do our best to preserve that, but some we're going to need to restore. If you're familiar with the vertical dimension of rest technique, that can be a great way to find VDO. The problem is that you have to decide how much you want to close from BDR to VDO. A lot of times 3 millimeters is used as a generic amount, but studies have shown that it varies quite a bit from one person to the next. The one good thing about this is that we're going to have a prototype, so we're going to be able to evaluate our patient. This has gotten really, really popular in recent years. And what's unique about this is that this goes from the commissure to the corner of the eye. You take a measurement, put this under the nose. If the chin touches, you can say that's an ideal VDO with the bite closed. If the chin doesn't reach, you need to open. And if the chin pulls this down, you're a little bit, you'll need to close the bite a little bit. Even with patients who have a good VDO, this can be an awesome tool because you can measure it and record it in the chart. And then as you're going through the process, you can take out this instrument and see how it's going. Make sure you're not gaining or losing VDO in the whole process. I would say this has taken dentures and All-on-X by storm. If you haven't had a procedure for measuring or validating VDO, I would consider adding this. It's pretty easy to use and it gives you something to start with. Restorative space, huge factor in All-on-X. If you think about it, the majority of the force from the bite obviously is coming from the occlusion. So we need an adequate volume of material vertically to resist that force. We call the space that we're creating for the restoration restorative space. There's two definitions that you'll hear. One is from the tissue to the plane of occlusion, and one is from the bone to plane of occlusion. We're going to use bone to plane of occlusion here because that's what you can control on the day of surgery. If we decide to start a case without adequate restorative space, we're basically marrying ourselves and our patient to a long-term series of prosthetic failures. So don't let this bite you. Make sure that once you have your prosthetic plan, that you check and make sure that you'll have adequate restorative space for the restorative material you want to use. VDO and restorative space. One of the things that people sometimes forget is that if I need to open the VDO a little bit, it also gets me more restorative space without surgery. And this kind of points to the holistic nature of treatment planning. So until I get the teeth in position, I don't know how much alveoplasty I need. If I don't know what kind of restorative material I'm going to use, I don't know how much restorative space I need. So this all works together. As you get the tooth position and as you know the materials and as you've analyzed the patient, then you can decide, do I need alveoplasty? How much? How many implants do I need? Where should they be? We're kind of talking about each factor individually, but they're not siloed in real life. In real life, you put them all together to find that perfect treatment for your patient. So for your dentate and partially dentate patients, if you need to open the bite, you can, this shows a leaf gauge, which can be a tool. We need to find CR on our patients. As you guys know, bimanual manipulation is the gold standard for achieving CR and testing the TMJ. At times, we can use a leaf gauge that's more flat and not so angled like this, and use that to separate the teeth so that the patient can get into CR. When we're doing all-on-X cases, there's really no reason to restore to any occlusion besides CR because we have the optimum opportunity to make CR and MI coincident. If you have a denture patient, you can also use a technique like this, but you'll need to make sure you've relined the denture so that it's stable. Obviously, bite blocks. First, you need to trim the occlusion till you get to the correct VDO. And then again, you can use bimanual manipulation. Also, sometimes you can tell the patient they need to bite in their back teeth. And they're like, well, I don't have any teeth. You can tell them, pretend like you have back teeth and bite on them, and that can help, especially if they swallow to kind of localize. Sometimes I've seen a lot of cases where a person was partially dentate and they've had a habitual bite that was not CR. And so all of a sudden, when they get a full set of teeth, we wound up having a pretty significant occlusal discrepancy because they've seeded back into CR now, and so their MI bite with a full set of teeth doesn't work for them anymore. So it's really important that we establish that bite. Once we know where the bite should be, then we're ready to make our prosthetic plan. And again, we talked about we want to get our posterior teeth with as ideal a cusp form as possible. And we want to have one point of centric contact on each posterior tooth, preferably between the maxillary stamp cusp and the mandibular central fossa, especially for directing, with the exception of our tilted implants, directing the forces along the long axis of the implant and the long axis of the root of the tooth as much as possible. We want to have even centric contact on the anteriors, and then eccentric movements will have a cuspid rise and anterior group function, eliminating any interferences on the posterior teeth, so that way we have the most neutral muscular situation we can have. One of the cool things about All-on-X is that you have a treatment prototype built into the process. We're going to deliver prosthetic on the day of surgery, and the patient will actually get to wear it for a number of months. So we can make sure that the phonetics, the aesthetics, the occlusion is very worked out. So by the time we get ready to do that definitive restoration, we're getting a good result. When you're taking digital records, no matter whether you're using photogrammetry or simply iOS, this is sometimes called grammetry, everybody wants you to use an iOS for the majority of the scans. You'll use it to capture tissue, tooth position, opposing, bite. But when it comes to MUA position, that's the variable. There are so many systems out there, and there are more coming every time. So, this is a image of a 3D facial scan. I love 3D facial scans. So let's talk about the two major categories of MUA capture. One is photogrammetry. Photogrammetry is what started the all digital workflow. We talked about with iOSs, the way they do, they take a picture, take another picture, find the common areas, stitch it together, keep doing that until a three-dimensional image is built. Modern systems have minimized this, but there is the possibility of having a password type error where you stack, and you get cumulative tolerance stack up that leads to cross-arch inaccuracy. We'll talk about how some of these newer systems try to get around that. Photogrammetry doesn't work like that. Photogrammetry uses multiple cameras and kind of triangulates all the implant positions at the same time using a domino thing like this. Costs vary, but these systems are very precise. It is unusual, and I'd say rare. Can't remember the last time I saw one of these where a photogrammetry scan didn't fit perfectly. So these get a great result. The two drawbacks is that they're only good for capturing MUA position and they're kind of expensive. So you kind of need to decide if this makes sense in your practice. It'll definitely take fit off the table as a problem that you're dealing with, but you kind of need to decide if the volume of cases you're doing in your practice makes sense for that. Simply iOS is kind of the next evolution, I guess you might say. It's using either what's called central scan bodies or horizontal scan bodies that are turned so that they're very, very close to each other. And with a very defined workflow on a modern iOS, you can get near photogrammetry level position for MUA fit. Within this group, so these don't use any other scanner other than the iOS scanner that you already have. Within this group, I'd say it breaks down into two major groups, pure digital and digital analog. Direct Scan and Nexus, for instance, are pure digital. They don't make an analog file. You don't need an analog file. You scan it, send it to your laboratory. Truss, OptiSplint, and Exact all require a greater or lesser degree of splinting, and Truss and OptiSplint create a physical model. If you're doing a case where you need to bond tie bases or something like that, this can be a benefit. But I think more and more people are wanting to just do pure digital workflows. So in our company, we're finding the pure digital ones are the more popular. So let's circle back to our prosthetic pre-design. Okay, we did all this work. How are we going to use it? So let's talk about different surgical. We'll use it several times, but let's talk about how we use it for surgery. With freehand, we can convert the pre-design into a clear denture with the lingual spot. And then a lot of times too, we'll trim the buccal borders of the denture to show the alveoplast. Now it's not, depending on how it fits, it at least gives you a general idea of where things should go. And it allows you to do a prosthetically driven surgery freehand. With static or dynamic guidance, you import the STLs of the prosthetic pre-design, and with your dynamic, in other words, like Yomi or XNAV or something like that, you have that prosthetic up on the screen as you're placing the implants. With static guidance, like in sequence, the implant positions, when you see the plan, the implants are planned based on that prosthetic tooth design to ideally support them and to kind of plan what, like this case, what MUAs you might need. So the prosthetic pre-design not only becomes the template for your surgery, it also becomes, and we'll talk about this, it becomes the actual provisional that your patient will wear. So one of the huge variables is, when are you going to provisionalize the case? Are you going to do same day or next day provisional? Now, if you want to convert dentures, more power to you. That's the same day. It's very time consuming. I can do it, but I don't like to. So I feel like with digital workflows, the only straightforward same day one is guided. Because with a guided prosthetic, we can pre-drill it. We can shape the intaglio. We don't have to put, borders on it that you have to cut off. We can design it flat ahead of time and make sure that it'll fit over the implant positions. There's still a little bit of work. We'll talk about that on the next slide, but it does give you the ability to start your surgery and finish and get a provisional in the mouth. With a digital workflow that we're going to be talking about, there's no converting. You screw it in. So that's the good thing. The challenge is that it's very difficult to deliver it on the day of surgery. Even if you have a printer, there's a certain amount of time to design it, print it, wash it, post cure it, and then apply the pink. It's going to take a few hours. And so you got to either have your patient wait around or deliver the next day, even still. So, with either freehand in a digital workflow or guided, in general, you're going to want to plan on provisionalizing the next day. Can you get a good result with both? Absolutely. It's more how you want to structure your practice and what works for your patients. Some people think, well, I don't want to deliver the next day, but there's some advantages to that. The first thing is that the person's jaw is in a little better shape, so you can feel more confident if you're doing occlusal equilibration. Generally, if you're doing that on the day of surgery, you got to kind of just rough it in because the patient's going to kind of settle in a little bit once they recover from having their mouth open for a couple hours. And then the second thing is that they're not loopy, so they can appreciate it. And it's a great time to get videos and testimonials and all that stuff. So for prefabricated same day, I believe that our company in Sequence has the best solution in this space. You can do guided alveoplasty, guided implant placement, and then you have a prosthetic like this that comes with the holes all drilled and ready to convert. It's not that hard to convert one of these in half an hour, and oftentimes you can do it in 20 minutes. And it just is kind of nice because you just go through the process. The patient goes home with a provisional. And then when you get to the definitive restoration, you can do the digital workflow that we're talking about. So if you don't want to do that, let's talk about the digital workflow. Here's that slide I warned you about. So this is now what we're going to be following. So we've kind of finished the theory part, and we're going to start talking through, like, how do you do this digital workflow? So the first appointment, you're going to take your pre-surgical scans or your pre-surgical records. So we'll talk about photos first. Again, if you're doing 3D facial scans, that's awesome. Take 3D facial scans with a variety of different lip positions so that we can evaluate our design against those. If your patient wears a denture, we'll talk about this in a little bit, you need to do an impression reline inside the denture to make sure it's stable, but you'll want that done before you get the photos, so that way the denture is not flopping around, that you'll have a reliable position. We want to make sure when you're taking the photos that the hairs behind the ears, tops of the ears are between the eyes and the eyebrows, so that you get the right anterior posterior level, and that the interpupillary line is level relative to the camera. So once you get the right setup, you want to take a headshot with the Duchenne smile. Again, critical, you got to see that high lip position. Do whatever you got to do until you get that. For a mandibular case, if you ask the patient to say shh, that can be a good way to see the mandibular transition line. If you have your patient say Emma and then take a photo right after, that will relax that upper lip and let you see how much incisal edge display you have right now. And then with the labial angle at about 15 degrees, you want to take a profile picture with the relaxed lip and the bite closed, and also profile picture with the patient smiling both closed and open. That'll give us a nice range of photos to be able to evaluate the patient. We want to get a good smiling photo because that workflow that I was showing you with the teeth aligned to the photo works well with that. CBCT scan, a lot of times we're using this for visualization. With guided cases, we're using it as an IOS of the bone, so it needs to be very, very accurate. One of the things you can do is take the scan with the bite open. That'll help cut down on scatter. Remove any partials that the patient has before taking it, and set the voxel size at 0.3 of a millimeter or less. If a patient wears a denture and you have a CBCT scanner, the dual scan protocol is great. You'll go ahead and reline your denture and put some markers on it, 6 like you see here, and then you begin by scanning, putting your plate in your scanner, put like a foam block on top of it so that you don't get scatter from the plate, and then scan the denture. Scan the denture first because saliva can make these markers move, and we don't want them to move or it messes up the accuracy of the alignment. But anyhow, once you've gotten that first scan, then you can put the denture in the mouth and have the patient close. With dentures, they're radiolucent, so they don't create a lot of scatter. So you can go ahead and have the patient bite into CR, and we can actually use that as a bite registration. So if you're doing a double arch case, a person who has double arch dentures, you'll do 3 CBCT scans and then take an IOS of the tissue. If it's a single arch denture, you'll do this reference denture scan, and then you'll also do an IOS scan of the opposing and the bite and the tissue as well. You can use this double scan workflow with bite block if you want. We need intraoral scans. So for your dentate patients, you want to make sure that you take a scan that's big enough for a denture. You guys know that scanning tissue isn't easy. You're like, why do I need all that? The reason is because of file alignment. We're going to be stacking a lot of files on these to build your digital patient. And if we don't have a complete scan, then there's a certain amount of luck involved if you capture common areas between the various scans. If you start with a very large scan, it makes the file alignment process much more reliable later. The other thing to keep in mind is sometimes you may want a backup denture, or you may be doing a clear denture workflow for freehand surgery. So if you discipline yourself to always take a denture size scan, then you don't have to change your workflow. If the person wears a partial, it's like we talked about, take the CBCT scan with it out. And then when you take your IOS scans, again, we're going to be aligning the IOS to the CBCT. So we'll need one IOS with the partial out for alignment, and then we need one with the partial in so that we can build the occlusion. I would recommend taking the photos and the bite scan with the partial in for your partial wearing patients. Here's a good example of a couple of nice denture scans. One thing you want to keep in mind with edentulous patients and digital workflows is that tissue, as you know, is kind of movable. And so aligning the before surgery scan and the first surgery scan that we're going to talk about later can be a little bit difficult. Sometimes you might want to use a CBCT scan with the reference screw in place. And I realize I'm talking about things I haven't covered yet. So let's just say this. If you have edentulous patients and you're worried about potential file alignment, go over it with your laboratory ahead of time so that you can come up with an effective file alignment plan before we get going. Here's my video picture again. Why do we have it here? The reason is that I would argue that the best time to take a big swing at things is with the provisional prosthetic. The reason is because we have that built-in evaluation period, and we're changing the person's whole mouth anyhow. Even if we didn't change anything, there's going to be a certain amount of adaptation involved. So this is going to be a great time for the person to get used to it, and at the same time for us to kind of use that prototype to evaluate everything and know that when we get to the definitive restoration, we're going to get a good result. I feel like you want to do big changes on the provisional, and then when you get to the prototype, make smaller changes, and then we want to make sure that the definitive restoration is the same as the prototype. Man, I'm sure you guys have dealt with single implant situations where your laboratory called you and said, I'm sorry, we can't make the, I don't know what, we can't make a custom abutment on this case because there isn't a custom abutment file associated with this scan body. You're like, what? But our digital workflows are similar. There are defined workflows that are associated with each of the scan bodies. And while truthfully, we can kind of work around it in different situations, you need to know that when you choose a given photogrammetry or simply iOS system, you're kind of choosing the direct MUA screw you use and things like that. So again, talk to your laboratory before you make a commitment to a system and make sure, hey, this works. This has that workflow that I really want. The more aligned it is and the less workarounds we have to do, the more predictable we're going to be. Day of surgery scanning is difficult. As you can see, you'll be scanning odd-looking things. You'll be scanning in a bloody field. You'll be scanning under time pressure. So it's good to develop this skill before you need it. I would say reference dentures are a good way to practice, but make sure you have a person and a backup person that can take these day of surgery scans because they need to be perfect. If they're off, we'll talk about this, the occlusion of the tooth position will not be the cool result that you planned. So you've taken all these scans, you send them to your laboratory. What do we do with them? We align them all to each other, and then we virtually extract the teeth, and then we'll do the pre-design. Most labs, this purple in the background is kind of a dead giveaway. This is an exocad design. Most labs that do full arch are using exocad. Some use 3Shape. You'll notice those have a gray background. With exocad, there's a thing called Web Viewer, and it lets your laboratory turn on whatever files you'd like to see and send you the files in the cloud so that you don't have to have exocad on your computer. You just click on the link, and then you can look at how does this relate to the photo? How does this relate to the pre-op? How does it relate to the occlusion? You can take a good look at it. And if you want, you can even share it with your patient. And we can make sure that this is exactly the prosthetic pre-design that we want, both, again, to guide our surgery and to be our day of surgery provision. All right, so here's our slide again. So we took all the records, we got the pre-treatment plan done, and now we're ready to do day of surgery and get the person in a provisional. And again, this will be a day after provisional. So when I was young and we were doing analog all on X, we spent so much time on fit. Any of you that lived through that, you know what I'm talking about. You put open tray impression copings, you lute them all together with dental floss, pick them up in an open tray, agonize about what impression material you're going to use, do your verification jig, and for us, models, altered models, is a pain. What's funny is that with these new digital workflows, that's done. Like, you're pretty much guaranteed a good fit. But you're not guaranteed a good result. And the reason is because of file alignment. When we have problems with file alignment, since all the MUA positions are captured at one time, they're going to fit. But if they're canted relative to where they should be, what happens is that we get irregular occlusions and, in extreme examples, poor tooth position. So when you're evaluating these cases, if you get tooth position that isn't what was planned, let's say that, it's either pre-op records or possibility, or it's a file alignment issue. So that's why we're talking so much about file alignment, because file alignment is the connection between the pre-design that you want and the result that you actually get. So how do you do the day of surgery? What are the scans? I'll go through the surgical phase briefly, but I want to focus more on the scans. So the first thing, you're going to do a reference screw scan. You'll do surgery. We'll capture the MUA position, and then we'll get a tissue and MUA scan. So at the beginning of surgery, you want to make as few alterations as possible. We need to put some reference screws in the patient's mouth. On the maxilla, we'd like to put 2 along the midline and the palate, and on the mandible, we'll put at least 2 in the retromolar pads and preferably 1 more in the anterior. Why are we doing these things? The problem is that from before surgery to after surgery, almost everything in the mouth is changing. And again, we need to accurately relate the after surgery files to the pre-surgery files so that we get exactly what we planned. What this is for is what I call a handoff. So before, the pre-design is aligned to the patient's preoperative tissue and especially teeth. So what you do with this scan is you place these reference screws, you scan a big scan of the mouth, scan the tissue, and especially scan the teeth. And what we're doing is we're handing off the alignment from the teeth to these reference screws. Now you might ask, what are the implications of that? You cannot move these. These can't move. If they move, you're guaranteed to have file alignment problems. So it's really important to get a good scan. Make sure you scan every surface of these. Take your time on this. This is an intermediate scan. We're not going to ever make anything on it, but it's critical to get the post-surgical files aligned to the pre-surgical plan. Again, on the mandible, this is an ideal situation, 2 in the retromolar pad, 1 in the anterior. And you can see how all the teeth are here. So we'll talk about the alignment process in a minute. But once I've aligned these teeth with these reference markers, now I don't care what happens here because these are my stable point of reference for the rest of my alignment. And we talked about this, so I'll skip over this. So now you do your surgery, reflection, extract the teeth, alveoplasty, place the implants. Guided surgery can help you put them where you want them. I put in a little thing about implant stability. Like we talked about, our patients want teeth in a day, and we want to make sure we can give that to them. One of the things we have to keep in mind, I'm sure you guys are aware of this, but there's a bit of a dip here in our total stability. So even if we have awesome ISQ or torque, we know that it's going to drop off a little bit. As we're planning these cases, we need to make sure that we allow for this. We have, you might say, extra stability. A couple things I wanted to mention about this. One is that we're hearing a lot more about cumulative torque in general. If you have 125 Newton centimeters or more of insertion torque amongst all your implants, you can usually load from predictably. Second, we want to make sure as we're doing our cases, we have less than 150 microns of micro movement at each implant site, and we should get good integration barring any biologic complications. And the last thing is that if our prosthetic breaks, it's a huge problem because that's what's stabilizing the case. So you got to make sure that you repair any breakage between the teeth right away. All right, you got your implants in. You want to place your MUAs. You can see how the prosthetic screw on this is angled nice and parallel. And so now we're ready to take our second set of scans. And our second set will be our MUA position. And again, I'm using MUA position on purpose because we're always going to use an MUA. And what I care about, I kind of don't care where the implant is. I care where the MUA is because all my prosthetics are going to fit there. Photogrammetry, the native output of this is an Excel vector file. And you can't build cases on a vector file. So all of the software have ways to convert to scan bodies. So this scan body was never taken in the mouth. It was a big domino looking thing. The software has precisely converted it, but whatever you convert to, you need to actually have these in your actual office so that we can get precise alignment of it. I'll show you in a minute with that. In general, with photogrammetry, you'll want to take this scan with the flap open because then you can see and make sure that your scan bodies are seated. The biggest potential for error in this process is the seating of those scan bodies because, again, the scan comes out perfect. Simply iOS, some of them have dedicated healing abutments that are used for alignment and some don't. If you don't have dedicated healing abutments, you'll probably want to suture before you take this scan. If you do have a dedicated healing abutments like this system does, you can go ahead and take it with the flap open. Keep in mind, because this is an iOS scan, you'll capture tissue. Anytime you're scanning for one of these, with this case, you'd want to scan here and then go on kind of a sunflower pattern. You never want to scan thing, tissue, thing, tissue. You want to always be scanning on the precision scan bodies. Makes a huge difference. And then your last scan is going to be sutured tissue with an appropriate healing cap that can be used for alignment. So for instance, with this case, you have to put these healing caps in for scanning. With these case, this surface and this surface are the same. Most of the time, you'll want to have the healing caps such that you can just dismiss the patient with those in place. And then when they come back the next day, take them out and deliver the provisional. All right, so you did your 3 scans, your reference screw scan, your MUA position scan, and your tissue scan. You send it to your laboratory. What do we do with it? So we take our pre-design, and then we know that this is aligned to the teeth. So we have a model of the teeth that this is aligned to. So now what we're going to do is we're going to take this initial scan that has the unaltered teeth and the reference screw, and we line this up. So now this is in the correct position relative to our design. Next, I have my tissue scan with my healing abutments in place. And I have this. So I'm going to align this to this. And I mean, truthfully, I have a little bit of palate, but if you think about it, we're betting the whole bite and all the tissue position on this. That's why I usually use two and why the scan of this is so important. And then last but not least, we align this to this. When we finish that, now we have the effect of dropping the new tissue and the new implant positions under the pre-existing design. One other step that's really important is in the laboratory, we align a digital representation of the scan body to the scan bodies that you provide. And doing that accurately is the last piece of getting a perfect result. You can see that then the software drops the MUAs in, and then we can adapt to the tissue again, making it hygienic, put the screw holes in, and then we'll 3D print it. And we print it in tooth color. So we'll want to characterize with some pink and send it to you. Now, this is where the digital workflow is awesome. Guess how many cylinders you convert on this? 0. Pull the healing abutments. Usually have to push a little bit on the tissue because we're trying to kind of contour the tissue with this restoration. Screw it in. Other than the pressing on the tissue, this is a lot like delivering a definitive restoration. Because it's the next day, you can kind of call it a reveal appointment, and patient can bring friends. You can do a nice equilibration, make sure your occlusion's good and even if it needs any adjustment. And presto changeo, you're done. You got your provisional delivered. So, of course, patient needs to be managed during healing. One of the things you have to decide is how soft the food you want them to eat. Some offices do liquid diet for up to 2 months. Some offices, they start out with plastic fork food. You also need to decide when you're going to transition from no water pick and no floss to water pick and floss. As soon as the tissue is healed, of course, you'll want to coach your patient and evaluate, like, how are they doing with their hygiene? You know, it's so important. Again, like we talked about, if they were smoking before, they need to not be smoking. So, and last but not least, if for some reason these restorations are really strong, they're printed with a material that's ceramic reinforced, they're stronger than a PMMA. So you shouldn't see a lot of breakage with this, especially if you have adequate restorative space and good implant spacing, like we talked about. So, but if there's a break between the implants, you have to repair it or you'll get implant failure. So once the patient's all healed, now we're ready to go to the definitive restoration. And this is our last 3 appointments. So patient's been living with our restoration for a while, and we want to really understand what they like about it and what they want to change. Again, we've been working through it with them and making adjustments and getting it where it needs to be, but we want to get a really good feel for how they're doing with their speech, their chewing, all that, because we want to make the majority of the rest of the changes that we need to make, we want to make them between now and the next appointment, which will be the prototype. Make sure that anything your patient wants changed is visible in the records you send to your laboratory. Photos, you're going to do the same series of photos that we talked about before. And then you're going to do your iOS scans. So you're going to scan, well, I should mention this first. Double check the occlusion. Make sure you're in CR at the correct video. If not, find it and capture that with your iOS scanner. So you're going to start by scanning, let's say it's a single arch upper prosthetic. You'll start by scanning the prosthetic. It's really important that you scan about 5 millimeters onto the tissue beyond the transition line of the prosthetic. If you can do that, then it'll make the alignment much more predictable. You know how I am about my alignment, right? Then you'll scan the opposing, scan the bite. And again, the bite that you're scanning at this point is what you want for the definitive restoration. You can do a 360 scan of a screw retained prosthetic. You don't have to. One trick I would say is start on the intaglio side, and as you're scanning back and forth, deliberately scan some of the cameo surface so that when you flip over, it's not as hard to build the prosthetic. If you get your 5 millimeters of tissue, you don't have to do the scan. There are some patients who are going to be wearing a denture. And so for these, we'll want to do a reference denture scan, meaning reline it, be sure that we have the right bite, reline it with impression material. And then we'll do a 360 scan of the denture, again, starting on the intaglio surface and then moving over the cameo. We'll scan the opposing, scan the bite where we want it. You have to take a 360 scan of the denture with this. There isn't an option of just scanning the tissue. We'll take our MUA position scan. This shows a simply iOS workflow, but you can use your photogrammetry. Again, all the rules from before apply. You want to make sure that the scan that you're using is aligned to the screws that you want, the kind of screws that you want, that the MUA position scan and the tissue scan have similar references, so you can align them together, just like we saw in, let me flip back to this slide really quick, because I don't think I hit this as hard as I meant to. Here, if these and these are the same, then our alignment becomes very, very predictable, and we get the results that we planned. Back over here. MUA position. And then, of course, you'll scan the tissue. At this time, what you'll do is, if you're using photogrammetry, you'll need to use healing abutments. But otherwise, when you scan the tissue, you'll just scan it with the MUAs bare. Obviously, much easier to scan, not sutured, not bloody, etc. So we get the case, and what we're going to do is we're going to digitize everything, and then we're going to make whatever changes were asked for from the provisional. We'll have that 360 scan of the provisional, and so we'll make the changes. Again, you can get an exocad web viewer, so you can check this out yourself and share it with your patient if you want. Our goal is to make all the changes that we wanted to make in this prototype restoration. It's going to be made out of the same materials our provisional was. So you bring the patient in and you're going to do the try-in. This is an appointment where you need to be really, really picky, because in the laboratory, our goal is to duplicate this in a high-strength material. So your first step is you're going to take the provisional out and clean it, and then you're going to do a one-screw test to make sure it seats passively. And then once you get the rest of the screws in, you'll check your VDO, your CR, function, phonetics, lip and cheek support, neutral zone, buccal corridor, tissue adaptation, and how that affects her speech, high and low lip line, and then the patient's thought on aesthetics. You're going to want to take another set of photos, low lip, smile, and high smile, frontal, and profile. I'll talk to you in a minute about some of the records you take if you want to make major changes to it. If it looks good or pretty good, you can go direct to a definitive at this time. But if you need to make more significant changes, we'll probably want to do one more prototype. So test drive. One of the cool things about a digital workflow is that you can send it home with the patient. So if the person was wearing a denture or if they broke their provisional, that's okay. Give them the prototype. They can wear it. Other times you might want to wear it because there's some stuff going on. Let's say if the patient isn't sure if they like it at the office. Okay, let them wear it for a while and have them come back and get some feedback. What if they're not real comfortable with the bite? Again, let them wear it, do a little bit of equilibration, and get it really nailed down before we go to the final. And what if they're having speech issues or lisping, cheek biting, that sort of thing, and you think they're going to adapt? With this, you don't have to hope, because after all, you know what they say, hope isn't a strategy. You can actually let them wear it and see if they adapt. If they don't adapt, then let's figure out what we need to change and get another prototype. We do not want to do redos. The goals of doing prototypes and test drives is that we get something that the patient loves and then we copy it in something stronger, basically. So let's say there's issues. What do you do for different problems? If there's aesthetic issues, you have to take photos that capture that issue. If it's a little tiny morphology or something like that, and the patient isn't a mirror here person, we can probably make those alterations between the prototype and the final. If it's fairly major changes midline, angulation, buccal corridor, things like that, we should do another prototype because, again, we want a prototype that the patient likes before we go to finish. For bite problems, you want to adjust the bite until you get to the correct VDO and get them in CR and then scan it. It does not have to be perfectly even. We just need to have the correct jaw relationship, and then we'll put the teeth in the correct occlusion. So you'll scan the cameo surface of the prosthetic, capturing the 5 millimeters of tissue. You'll scan the opposing. You'll scan the CR bite. You'll send that to us, and we'll make an adjustment. If there's a tissue gap, we need to take a new tissue and MUA scan. And if you could take some pictures of the gap or at least describe it in millimeters in some areas, that can be helpful. Little changes, go to final. Larger gaps, especially ones that affect phonetics, we should do another prototype just to make sure. If the prosthetic doesn't fit, it's really, really rare, but you need to take a new precision scan, either photogrammetry or simply iOS. And then when we get it back, we're going to take the digital patient and alter that patient as necessary based on the new records you give us, maybe realign the bite or add the new tissue scan or whatever. And then we're going to tune up the prosthetic as you required, and then we'll make it in the definitive material. We'll talk about those in just a minute. Third appointment, deliver it, woohoo! And we've kind of been going from the person started with really bad teeth. We zeroed in quite a bit with the provisional, and then we zeroed in even more with the prototype. So now we know what the patient wants, and we had that on the screen when we did the design, so it can be predictable that the patient's going to get what they want. Again, you'll do your Sheffield test and check all the stuff we talked about at the try-in. Make sure you have the right polishing kit for the type of material you're using, and polish things up before you deliver it, especially with zirconia. Rough zirconia can tear up the opposing. Polished zirconia is very, very kind to the opposing. So the polishing is a huge variable on those. You want to make sure that you give them good instructions on hygiene and also set up a recall appointment based on how effective you think they're going to be. It's a good time to talk about costs if you're doing like a 4-locator case or something like that, replacement schedule and things like that. If you're going to be if you have a fix, talk about what your screw replacement schedule is. Some people like to do 2 screws every time they take it out. Current best practices is leave the prosthetic in unless you can't clean it. So today, most people aren't removing fixed if they don't need to be removed. And then have an appointment, an early appointment, just to evaluate hygiene and do some coaching. So what are some options? I'm going to talk about fixed and removable because we said some people need removable. Screw retained zirconia. I feel like today this is kind of carrying the day. They're strong, biocompatible, aesthetic. We can mill them from solid zirconia. We can use pucks that are variegated both by opacity and translucency and also shade to get a really, really nice result. So these are great. The main challenges with these are if they oppose each other, sometimes they're going to make a clicking noise that the patients don't like. There's no way to test it until you do it. So you kind of need to make a judgment with your patients. And if there's a concern, you might want to use something else. We need at least 12 millimeters of restorative space. But in general, with solid zirconia, we should only cantilever. We don't want to cantilever anything, but we only want to cantilever 1 tooth at the most, regardless of the AP spread. Titanium reinforced zirconia is getting more popular. So the titanium bar is one piece, and then the zirconia is a sleeve that goes over it. So you can get a very, very nice passive fit with this because there's no centering shrinkage. It's just milled from a puck, usually a block of titanium, which is nice. If you have a case not like this, but with where you need that 1.5 times AP spread, these cases can do it. You shouldn't do it with just solid mirrored zirconia. The one thing you have to watch out for with this is that if these implant positions are pretty much perfect, if the implant positions are off a little bit, the definitive restoration with the bar in it may be a little bit thicker in those areas than the prototype was. You'll need to talk to your patient about that. Nanoceramic, it's a nanohybrid composite over a high strength bar with tie bases. We're not finding these as popular as they were a few years ago. They can be nice if you're worried about clicking, because obviously these don't click. They can be repaired clinically if you get a chip or something like that. And they don't tolerate cantilevers well. So you don't want to use these in situations where there's a significant anterior or posterior cantilever. The other thing is that we have to bond the tie bases to place, so we need to do a hybrid digital analog workflow, whereas the other two can do pure digital. Thimble bridge, there's like 10 names for this, but basically what it means is a prosthetic with a substructure that looks like preps, individual crowns over it. And these days, this is what most people are doing, is a titanium substructure, pink composite, and then usually zirconia crowns over. They're very pretty. If you get a crown that breaks, you cut it off, scan it just like you would a prep. Sometimes we can do these a little bit shorter if there's limited restorative space, because your frame is solid titanium. Normally we'll do a Montreal type design on this, so the intaglio surface will have pink around the edges, but the intaglio will be polished titanium just like this. They're harder to make, so they're a little more expensive, but it can be a really good solution. And of course, the old hybrids can still make them. These days, of course, we use a milled bar. This part is a lifetime restoration. This will have to be replaced. So in general, you want to save the provisional and the prototype, but especially with these cases, because when they come in for a retread or something like that, a retread's when you replace all the plastic part of it, you want to have a good fitting provisional that's ready to go. Removable restorations for locator. The main thing I want to tell you guys about this is there's a brand new scan body from Medentica that lets you do a full digital indirect workflow. So you can put these scan bodies on, scan, and we can build a model with analogs to do the prosthetic. So that's a relatively recent invention. If you want to hear more about it, reach out afterwards. This is an awesome restoration for patients with poor hygiene. I mean, if you can't keep this clean, I don't know what to tell you. But the one thing is, sometimes patients get a little frustrated with the little bit of sponginess to it, and there is a fair amount of maintenance. Normally you have to replace these little inserts about every 6 months, and the abutments about every 2 years. Milled bars with attachments. Usually these attachments last quite a bit longer. If we do a cantilever here, we can have a pretty solid restoration. The main challenge with these is, even with the prosthetic removed, you still have a bit of a hygiene challenge here. So it is a good case if you need a cantilever, because you can cantilever the bar and then have the prosthetic be 100% supported by the bar. We need a fair amount of restorative space. We do some of these, but these are not, we don't do a ton of these. Conus. This is a restoration that I feel like we could do more of. You got to have exactly 4 implants, and they don't have to be perfectly parallel, but they have to be close enough to where we can make the abutments perfectly parallel. This is a custom titanium abutment. This is a gold alloy cap. When you press this down, the inferior border of this is warped slightly by the titanium. So when it's down, it's down. It doesn't move at all. It doesn't wiggle. It's nothing like a locator. It doesn't require a flange because it's entirely implant supported. And obviously the hygiene is still pretty good. The main thing is, for your patients, they have to take this out at least once a day. It can get cold welded. You can get a crown popper to get it off, so it's not welded, like it won't come apart. With this, there is a digital workflow, but it's very different than what we talked about. So again, if you want to find out more, let me know.